Good afternoon and welcome to today's webinar hosted by HFMA Region 10 Chapters. This is part 3 of a 4-part Medicare Bootcamp series. The discussion for today is Uncompensated Care Reimbursement Strategies. I would like to welcome our guest presenter for today's webinar, Chad Kerschel. Chad Kerschel is a senior manager with Crowe LLC. He has 25 years of national healthcare finance experience focused on regulatory reimbursement, revenue recovery, and project management. He is also an active member of HFMA. Chad is a certified healthcare financial professional and holds the HFMA designation of Fellow of Healthcare Financial Management. Chad is currently serving as an officer of the HFMA Colorado chapter as the president. He has served that chapter in the roles of certification chair, board of director, annual conference chair, and Secretary of VP of Education. He also presents Medicare reimbursement strategy courses on a national level for HFMA at courses throughout the year and at HFMA's annual conference. So without further delay, I will hand the call over to today's guest presenter, Chad. Please go ahead.
Thank you very much, and good afternoon to everybody. Thank you very much for taking your time today to listen to our Region 10 Medicare Bootcamp series. This is the third in a series of 4 Medicare Bootcamp presentations that we're presenting. And today we're going to talk about uncompensated care reimbursement strategies. So we're going to talk about S-10 and some of the fun things that are going on with S-10 right now. I'm going to talk about disproportionate share payments and how that's been affected over the last several years. And we're going to talk about Medicare bad debts. And one of the things we're going to talk about before we jump into that area is a little very high level section on revenue cycle. There are going to be some things throughout this presentation as we go through each section where we kind of talk about some key drivers of each one of those uncompensated care areas that I referred to, and what can be done to try to enhance reimbursement in those areas. And all of these really tie back to the revenue cycle. So it ties back to how the departments of reimbursement, of patient financial services, of revenue cycle, all the different departments work together. But we're going to focus on reimbursement and revenue cycle and the collaboration between those two areas, and really how by doing that, it will really help your Medicare reimbursement. So some of the objectives that I hope to cover today and that you will take away that you will take away after this presentation is be able to examine high impact areas of the cost report and understand by doing that what drives S-10 and our uncompensated care payments, DISH, and Medicare bad debts. There are some key drivers in each one of those areas that we'll talk about at the end of each section that hopefully you can take away from today's presentation and take a look at your own organization and see what's going on in those areas. So some takeaways from the presentation. We're going to talk about Medicare bad debt and some documentation that has to be maintained and submitted to make sure that Medicare bad debts survive audits. We're going to talk about charity care log elements. And then, as I mentioned, we're going to talk about key drivers of Medicare reimbursement as we go through this to kind of give you an idea of things that you can look at in each one of these different areas to enhance reimbursement. So the first thing we're going to take a look at is the revenue cycle. When we talk about the revenue cycle, there are three key components of the revenue cycle. We've got the front end, which I refer to as the patient access. That's prior to the patient arrival, everything that's going on prior to the patient walking into your front doors for the services that they're going to be receiving. And then what happens once they do walk in to that front door, and making sure that everything is captured that need to be. The middle revenue cycle is where that interaction, the services begin with the patient. And then the back end, which is an extremely important part of the revenue cycle. This is where we're doing our billing and our post-discharge financial management. So when we jump back over to the front part of this, the front part of that revenue cycle, we're talking about, the scheduling, registration, insurance verification, referral management, point of service collections. So what's going on in that front end that is going to help us capture all of the reimbursement that we need to capture going forward? So have we identified all the insurances that the patient has? Have we made sure if they are eligible for Medicaid, but maybe they're not yet a Medicaid patient, what are we doing to ensure that we get them Medicaid eligible? Have we looked at whether they're eligible for our charity care policy? And have we done everything we can to make sure that we meet our policies and those patients are indeed eligible for our charity care program? So all the different things that are going on there is really getting all the information from the patient and making sure that going forward, we've got all the elements that we need to have to know how to handle that patient on the financial side of things, on billing, charity care. What are we doing to eliminate bad debts by trying to do point of service collections? So a lot of things that are happening up there in that front end of that revenue cycle that really affects our reimbursement throughout the year, and once we are filing our Medicare cost report, how we're capturing that information. Then we move into the middle revenue cycle. So what are we doing to make sure we're capturing everything that's going on with that patient stays, and how is it accurate? So that when we come to the billing phase of this, we've got all the information and we've got a complete history of that stay and history of what happened during that stay, so that we can bill everything properly. And a lot of different things that fall into this when we talk about the Medicare cost report. But as I mentioned, the key things we're going to talk about today are DISH, Medicare bad debts, and our uncompensated care. So those in the next hour and 15 minutes or so, those are the different areas that we're really going to focus on, and how we can tie that back to the different drivers of those areas, and with collaborating and working integratively with the revenue cycle department, how we're making sure we're capturing everything appropriately. And then the back end of our revenue cycle, as I mentioned, that's where everything post-discharge and financial management are occurring. So what are we doing to make sure that we're billing everything appropriately based on everything that was captured? And what are we doing? A big piece of this is working our denials. A lot of different things go into billing, and a lot of things come back denied that have to be worked. And are we doing everything that we can do to work those denials and make sure that we get the proper reimbursement? Anything that needs to be changed is changed, so that we can get those denials back on the payment track. When we're talking Medicare, obviously a lot of things are based on the DRG payments, Medicare DRG. So if for some reason we're having issues with billing or denials in that area, that's going to affect a lot of the different payment methodologies that we're talking about, and will decrease reimbursement in those areas. So by having a understanding of those areas and what goes on in each one of those, and making sure that the reimbursement and the revenue cycle departments are working together, that will really enhance these different areas and enhance reimbursement. So just a few areas under each one of those things that we just talked about, with that front end access, the patient access. You know, when we're talking about the DSH payments, it's extremely important that we have identified all of our Medicaid eligible patients, or those that would be eligible for Medicaid that are not yet Medicaid, have Medicaid as an insurance. What have we done to make sure that we have got them eligible for Medicaid? And even if they're in that pending bucket right now, at least they're moving forward in that Medicaid verification, so that at some point we're able to claim them in our disproportionate share payments, which we'll be talking about here shortly. Charity care determination. You know, what are we doing up front to make sure that we're going through all of our processes and policies to make sure that if that patient is eligible for charity care, we've documented that, and we've done all of our tests to make sure that they are eligible for charity care, which of course is going to help us with our uncompensated care payment of the DSH payment that we now get. That's another area that we're going to be talking about. You know, that, as I mentioned, you know, reduction in bad debts. What can we do up front? What are we doing up front, point of service, to eliminate our Medicare or any type of bad debt? But of course, we're going to talk about at the end of our presentation what a Medicare bad debt is, and what are some of the things that can be done to make sure that we're getting the reimbursement that is due us for our Medicare bad debts. Moving forward, you know, capturing all of this information, you know, CDM, charge capture, coding, what are we doing to make sure that we have captured all of that information throughout the patient stay, so that we can make sure everything's in the correct financial classes, and we're billing appropriately, depending on whether we're billing, you know, inpatient or outpatient Medicare stays. If you're a PPS hospital, you know, are you understanding what DRGs it needs to be coded to? Obviously, critical access hospitals are paid on cost, so making sure that we're capturing everything charge-wise, and our cost-to-charge ratios will come out correctly in the Medicare cost report. Extremely important that we're capturing everything in this area to make sure that at the end, through our Medicare cost report, we're reporting everything properly. And then really on this slide, the big thing that I want to hit here is that third-party denial. What are we doing in this area to make sure that we've got processes in place, you know, to analyze and appeal if necessary, or rebuild these claims, to make sure that whatever reason it was denied, we are trying to correct that to make sure we're paid correctly. Again, as I mentioned a little bit earlier, the big area here that this impacts is Medicare DRGs, as that is a big component of many of our methodologies of payment through Medicare. So we want to make sure that those types of denials are being worked and being resolved, to make sure that that piece of that puzzle is correctly reported. We're going to talk a little bit about uncompensated care, and well, a lot about uncompensated care over the next hour. The first area that we're going to talk about is DSH, or disproportionate share payments. So these are payments to hospitals that serve a high population of vulnerable patients. So, Medicaid beneficiaries, low income, Medicare beneficiaries, uninsured and underinsured population. So this is basically an additional payment for hospitals to address the burden that they take on by serving these patients and may not be getting payments by providing these services. So this was an additional payment that they would receive that came into play back in 1986. So it was really started to come into play, as you see there, in 1982, and then through the intervening 4 years as things progressed, it came to the point in 1986 where hospitals started to receive disproportionate share payments. So how does a hospital qualify as a disproportionate share hospital? So there are two things to go in that go into this qualification. The first one is the Medicare fraction. So this is the days of patients entitled to Medicare Part A divided by total days of patients. So that is what is referred to as the SSI portion of this fraction, and that's provided to us by CMS. So that is information that comes out annually based on that information. It's also one of those things that over the years have undergone quite a few different changes as to how that number is calculated. Unfortunately, it's also an area of a large amount of appeals that go on because that number, in some cases, is hospitals believe it's incorrect based on what was going on in that information. So that's one of the reasons that over the past several years there's been a lot of different changes to how that number has been calculated. But even with the most recent changes, there still are issues with the numbers, and there are still appeals going on regarding the SSI. The second portion of this percentage is the Medicaid percentage. So this is days of patients eligible for Title 19 Medicaid, but not entitled to Medicare, divided by total patient days. So that's your Medicaid percentage. That is the percentage that hospitals have a lot of control over and need to really scrutinize that number. So they want to make sure they're looking at their patient population and identifying all of their Medicaid eligible days, paid or unpaid days. And they want to make sure they're capturing any out-of-state days that may be part of the population. So as I mentioned, this is one of those areas that with the work that's done up front in the revenue cycle to identify these patients and make sure we get them eligible for Medicaid, that front end work goes a long way towards, at the back end, allowing hospitals to understand and be able to identify each of the Medicaid eligible days to make sure that they get that in their Medicaid fraction piece of this percentage. So with the Medicare fraction and the Medicaid fraction, those two added up, if you're over 15%, you would qualify to receive disproportionate share payments. If you're over 20.2%, there is a higher payment that you would receive. So there's different factors that are included in the calculation that would allow you to receive higher dish payments. So important for you to make sure that you've identified all of your Medicaid days to make sure that you're over that 15% to qualify for this payment. And then, of course, continue to identify those and maybe getting over that 20.2%, which gives you even higher payment. Now, as we'll talk about a little bit, obviously this part of the dish payment has decreased over the past years. It's this portion of what you receive through DISH is now only 25% of what you normally get. But still, that's a lot of money for a lot of hospitals. So you still want to make sure you're working this portion and getting this percentage as high as you can. Another area where this is a big factor is with hospitals that are 340B payments. So the 340 or 340B hospitals, the 340B payments are tied to this DISH allowable percentage. So here's a table of the DISH percentage, the allowable DISH percentage that hospitals need to have in order to qualify for 340B. Now this, you'll see in that third column, the DISH percentage, and you'll see for the top three there, it's 11.75%. I want to make sure that you understand that this number is different than that 15% I was talking about earlier that you need to qualify for DISH. So the 15% that we talked about earlier, that's what you need to qualify for DISH payments. This 11.75% is what needs to, after it goes through the calculation, the DISH calculation, it's going to come out with your allowable DISH percentage. So that piece of it has to be over 11.75% for PPS hospitals, children's hospitals, and freestanding cancer centers to get 340B payments. If you're a critical access hospital, basically you automatically qualify for it. If you happen to be a rural referral center or a sole community hospital, that DISH percent has to be over 8%. So again, you can see why it's extremely important for hospitals to make sure they've identified all of their Medicaid days to be able to qualify for DISH and to be able to get that DISH allowable percentage as high as they can to qualify for 340B, or if they already are a 340B hospital, they don't want to fall below that threshold and lose their 340B status. Now, if you're a 340B hospital, you've seen a lot of changes that have occurred with the payment for 340B drug. So over the past year, that payment that you've received on this has been decreased approximately 30%. It was one of those areas that CMS looked at and made some changes to last year, and the payment that you had been getting, as I mentioned, was about 30% less than what you normally had got. So that's really about a $1.6 billion annual cut to hospitals to the 340B payments. So, you know, it's still extremely important to hospitals to have this 340B, but definitely a lot of decrease in payment just in that one area alone. You know, this 340B program was really a program to allow safety net providers to kind of stretch their scarce resources to be able to serve these low income patients. You know, and one of the I'll say one of the issues around this is that you know, CMS thinks that maybe some hospitals are not using this funding to pass services on to patients, but maybe to be increasing profits. So that's one of the areas where they were looking at and why one of these payments decreases happened. So really important for hospitals to protect their percentages as much as possible, and obviously a lot of issues around this that are being looked at to try and increase payments as much as possible. But that is one of the areas that hospitals have been hit with a decrease in this area. Another area that's come up with 340B that they're looking at right now, this is not changed right now, but it is something they are looking at. As I mentioned, hospitals need that 11.75% to qualify for the 340B payments. but it is that percentage is being looked at being raised. So the number that's been thrown out there is to raise that 11.75% up to 18%, which if that would happen, it would eliminate about 570 DSH hospitals, so about 51% of DSH hospitals would be eliminated if that were to be raised to 18%. So it's a pretty large decrease in payments for 340B hospitals or those eligible for 340B. So that's one of the areas in the 340B funding that is being looked at right now that I'm sure if you're a 340B hospital, you're aware of. So moving through the DSH, what's going on with DSH payments. With the Affordable Care Act, which came into play in March of 2010, there were significant changes that were laid out for the Medicare DSH adjustments. These came into play starting in fiscal year 2014. So basically that traditional DSH payment that you had received was cut by 75%. So that say you received $5 million of DSH payments traditionally, that payment would be decreased by 75% and you'd be receiving 25% of that amount. That remaining 75% basically went into a pool and is redistributed back to DSH hospitals based on the amount of uncompensated care that hospitals give to patients. So it became extremely important that the uncompensated care payments be captured properly. Well, when this first came into play, as I said back in 2014, they decided to use a different number than what was reported on the Medicare cost report on S-10. For several reasons, chief among them is, that S-10 information hadn't really been audited. Instructions around the S-10 and how to capture that information really wasn't well laid out, really pretty vague, non-existent in some cases. So they weren't yet confident enough in the number that was being reported to start using that information. So in 2014, 2015, 16, and 17, CMS was using a low-income insured days, which was very similar to the SSI information that we talked about earlier, to capture the payments, the hospital's portion of that uncompensated care pool that we just talked about, that's 75% made up. So the Affordable Care Act itself is estimated to expand coverage to about 32 million Americans by 2019, and this would cut DSH payments to hospitals by about $22 billion between 2014 and 2019. And basically, the reason for that is hospitals caring for fewer uninsured patients. Was the theory behind this new payment methodology. So if we take a look at this next slide, this grid that I've laid out here, this kind of shows us from 2014 through 2019 where the DSH payments and that uncompensated care payment lies right now. So let's take a look at that first column, the DSH estimate. That would be the amount that would have been paid to DSH hospitals with no changes in the calculation. So you can see there from 2014 at 12 billion, and then 2019 16 billion that would have been paid to hospitals if nothing had changed in this calculation. That next column there shows that 75% reduction of DSH. So that's that pool that was created by paying DSH hospitals the 25% and this other 75% pool of payments, that a portion of that would be redistributed back to hospitals based on a couple of different factors. So the first factor is that percent of uninsured. So you can see in 2014, that percent was 17%. And over the next intervening years through 2018, that percent of uninsured had decreased. So it went from 17% down to 8.15% through 2018. And then you can see in 2019, it starts to creep up again, and is predicted for 2020 that it will kind of creep up higher than that. So that basically what we're saying there is the percent of uninsured is starting to creep back up. So that when you go over to the next column, you can see that factor 2 percentage. So this is based on that uninsured number. That was 94.3% in 2014. Again, continued to go down throughout the years, and then creeped up in 2019 because the percent of insured went up. So that factor 2 percentage, which is based on the percent of uninsured, is then multiplied by that column 3 over there, our pool that we've got there. So in 2019, that pool that's there is over $12 billion, multiplied by this 67.51%. So that gives us the dollar amount that is redistributed back to the hospitals. And in 2019, that amount is $8.2 billion. So you can see again that kind of the moral of this slide is the decrease in the uninsured from 2014 to 2018, and then now it's starting to slip back up. So that pool, as you can see at that last column there, has increased from 6.7 billion in 18 to 8.2 billion in 2019 that will be redistributed to DSH hospitals. So this is just kind of what I already mentioned on that grid there. This is kind of the wording or the each factor, what each factor stands for. So factor 1 within this DSH payment is that 75% reduction of the DSH. So that gives us that pool. Factor 2, as I mentioned, is based on the uninsured population. And we saw what that population was, and once it goes through that calculation that you see there at the bottom, that's what comes up with that factor 2. Then factor 3 is really the factor that's been in the news, that's making all the noise and all the highlights. So this factor 3 is the hospital specific portion of that uncompensated care pool. So based on this factor, hospitals get their share of that $8.2 billion. So as I mentioned, in 14 through 17, that factor was based on low income days. So it was similar to how the SSI was calculated. In 2018, that changed. So they started using numbers from the S-10. So the information that was reported on S-10 became extremely important. And the number that goes into the hospital's uncompensated care, if you were to be looking at in S-10, you'd see line 30 on that cost report. And line 30 is made up of charity care and bad debts. So non-Medicare bad debts goes into that number that goes on to line 30. And line 30 on S-10 is what's used for the hospital's portion of the uncompensated care. So in 2018, that number started being used. So it was a kind of a phase in of some on the low income and then some based on S-10 information. And then over the next 3 years, that's being phased in. So those are kind of the three different factors that make up how that uncompensated care is determined for each hospital. So just a couple things to kind of take into consideration when we're talking about this is that, again, here's some of those key drivers. And what makes these key drivers really as high as we can get them? What can we do to make sure DRG payments are as high as they should be? Medicaid eligible days are as high as they should be. Again, that collaboration, working with the revenue cycle team, that revenue cycle process that we mentioned, front end and back end especially. What's being done to identify those Medicaid eligible days? Is there a process in place to identify all of the Medicaid eligible patients and identify those that are eligible for Medicaid but not yet on Medicaid? Those processes should all be in place on that front end to make sure we're identifying our Medicaid eligible days to increase our DISH payments. And of course, the DRG payments, as that all comes down to what we're doing to make sure we're billing properly. So number one, are we billing everything we should be billing? Are we looking at things like transfer payments? So where did this patient actually get discharged? So when they were discharged from the hospital, were they discharged to home or were they discharged to another post-acute care setting, which is going to determine what piece of that DRG payment is actually paid. So if for some reason the patient's discharge orders at first say that they should be discharged to a post-acute care setting, and they were really discharged to home, are we looking at those situations to make sure that we're getting the full and proper DRG payment that we should be getting? Are we looking at those denials that I talked about earlier? Are we working those denials? Have we got all the updated rates, new DRG weights, everything that needs to be updated each year? Are those all updated in our system so that we're getting paid our proper DRG payments? So you can kind of see how this really ties directly back to a lot of different things that are going on in the revenue cycle to make sure that we're getting the proper DISH payments that we should be getting. So with that little history of DISH, we'll talk a little bit about S-10 and uncompensated care now. So as we mentioned, that Patient Affordable Care Act that came in 2010 made a lot of different changes to that DISH formula and created this uncompensated care payment. So if you were to be looking at S-10 on the Medicare cost report, you will see that there are several different components being reported on S-10. They're looking at Medicaid shortfalls and all the different state programs. All that information is reported on S-10. And then charity care and bad debts, total bad debts, are all components that you would see on S-10 if you were to be looking at that worksheet. So a lot of different components that go into that, and all of those components are used in different ways. But for what we're talking about here, the S-10 uncompensated care portion of the DISH payment that hospitals should be receiving, CMS decided that what would make up that would be the charity care and the non-Medicare bad debts. So on S-10, that would be lines 23 and 29, and those two numbers added up on line 30 is what goes into the uncompensated care amount, uncompensated care cost for the hospital. So just a little bit of memory refreshing here. That traditional formula is determined based on the SSI and the Medicaid Title 19 days. And with the Affordable Care Act, that traditional formula was, DISH payment was slashed by 75%. And then that portion is redistributed back to hospitals based on that similar SSI portion of the payment. So as I mentioned, starting in 2018 is when they finally started to use the S-10 information. Before that, they were using a different methodology. So starting in 18, they started phasing in. So 2 years of that proxy data, that low income days, 2012, 2013, and 1 year of the S-10 data, which was 2014. Then moving into 2019, that's based on 1 year of the proxy data, 2013, and 2 years of the S-10 data. That'll be 14 and 15 for the 19 payments. And then right now, the way it stands is in 2020, it will all be the S-10. So it'll be 3 years of S-10, 14, 15, and 16 data that will determine that uncompensated care portion for your hospital. The uncompensated care payments are the cost of charity care on line 23 and the non-Medicare and non-reimbursable Medicare bad debt. That's on line 29. So this obviously really called into, or really kind of made the information that's on S-10 information that needs to be audited, needs to be looked at. You know, MACs want to look at that and make sure that the information on line 23 for your charity care and the line information on line 29 for the bad debts is correct. So, you know, audits, you know, reviews of this started last year and really go as of 2019's final rule. The instructions to the MACs are kind of still under development as far as how they're auditing this information. You know, the cost reports, expect cost reports beginning in 17 that really will be the first with S-10 that are subject to desk reviews, and 14, 15, and 16 would be under scrutiny. So that information would be being looked at. Well, as I mentioned, as of the final rule, that is still under development. But some of the final rule highlights are CMS is going to continue to refine their efforts on S-10 as far as instructions, data submitted by hospitals based on what has been learned. So based on the review process they've been doing, there'll be some further refining of what's going on with S-10. Those instructions to the MAC are still under development. The MAC's obviously got guidelines as to how these audits need to be handled. And those audits were expected to begin in the fall of 2018. So we're in that period right now of those audits. I want to skip ahead a little bit here and kind of talk about the audit requests. So as I mentioned, we're in the midst of those audits. Your hospitals, if you were chosen, would have got letters sometime in September. The letters were supposed to be out by the end of August, but we know that some of our clients had still been receiving those into September. But for the most part, everybody that were selected for audits should have by now been notified of their audits and what needs to be done. So they really started, what they did was they started looking at fiscal year 2015 cost reports for these audits. So those beginning on or after 10/1 of 2014 are subject to the audits right now. And each MAC has been tasked with auditing 50 hospitals, 50 reports, and these all need to be completed by the end of January. And this will most likely all be taken into account, the HCRAS data for the 2020 inpatient rule process. rulemaking process. So that's why this all really needs to be done by the end of January. As I mentioned, those letters, if you're one of those hospitals, you received that information. Timelines for responding to the documentation is approximately 2 weeks. So I think most letters are saying you have 2 weeks to respond to that. And you can get, in most cases, have extended that or got an extension on to giving them that information in additional week. So for the most part, from the time you get that letter, you have about 3 weeks to respond and give them the information. And some MACs are utilizing contractors, so they've contracted this work out to have these audits performed. So just a little bit of information regarding the audit request letter. So those hospitals that have received these letters and are under audit, the request letters are large. I guess I'll put it that way. There's a lot of information that is being requested. It's about a 3 to 4 page request letter. And some of the things that we've seen that are being asked for are charity care policies, financial assistance policies. You know, they're making sure that you know, you're following your policies and what you're doing, whatever's being included in your charity care matches what your policy says. You know, descriptions of the logic and processes used to obtain your detailed listing of your charity care charges. So obviously part of what has to be given is the charity care charges that correspond to what you've reported in the cost report, and how was this information pulled. Submission of detailed listing of claim charges is another thing that's being asked for. Detailed listing of all bad debts for the hospitals, including Medicare and non-Medicare, so these are just a few of the things that are being asked. So there's a lot of information just in these 4 bullets that are being asked for during these audits. So hopefully, if you've received these letters and that you've obviously started pulling the information and can get all that information to them within the 2 to 3 weeks time frame. So just a quick overview of uncompensated care as far as what we're talking about when we're talking about uncompensated care. So in this case, for these payments, uncompensated care is charity care and bad debt information. So that will include Medicare bad debt, non-Medicare bad debt, non-reimbursable Medicare bad debt. So basically what we're saying, this is saying here is, if you're reporting Medicare bad debt and are getting paid for your Medicare bad debt through the cost report, you're getting that 65% payment. And one of the components of the bad debts is charity care bad debt. That charity care bad debt cannot be included in your charity care, and the Medicare bad debt that you're being reimbursed cannot be included as uncompensated care, because you're already getting reimbursed for that through the bad debt mechanism. So they want to make sure you're not getting paid for that through this uncompensated care mechanism also. Charity care, again, the policies around charity care are extremely important, but really the thing to remember here is the hospital has to determine their eligibility for charity care. So they have to go through their processes, whatever their policy is saying, to determine that the patient is unable to pay. And basically what we're saying there is, the patient can't come in and say, I'm not able to pay my bills, and you give them charity care. The hospital has to follow its policies, and it makes its determination of whether the patient is able to pay or not, and be able to document if what information they looked at to document that they are eligible for their charity care. Non-Medicare bad debt. So that's charged for health services for which a hospital determines the non-Medicare patient has the financial capacity to pay, but the non-Medicare patient is unwilling to settle the claims. So that's one portion of that. And non-reimbursable Medicare bad debts is that piece of Medicare co-insurance deductible that's considered uncollectible and not reimbursed by Medicare. So the fee screen type of things would fall into that area for this definition. One of the things that makes the charity care process a little more difficult is depending on the audits that are going on. There's a couple of different ways that the charity cares were allowed to be reported. So before October 1st of 2016, the charity care would be for care delivered during this cost report period for the entire facility. So that's for the charges that were written off and delivered during this cost report period. Whereas after 2016, it's by service date. So it's written off during the cost report period, regardless of when the services were provided. So if it was written off in that cost report period and the services were provided the year before, that could now be a charity care number for after October 1st, 2016. So some of the key drivers here around the uncompensated care is, the key drivers: charity care reporting and bad debt reporting. So the opportunities and things to be working with patient financial services and other areas of the hospital is, what the charity care eligibility policy says, the financial assistance policy and charity care eligibility agree, making sure those things match. Making sure that everything that's in the policy or whatever you're doing to identify those are part of your policy. Transaction codes. What transaction codes are being used to report charity care and bad debt, and are those the only ones being used? Is the team reporting used to other codes where you're not picking it up? So really having that education and that information there as far as what codes need to be used to capture this information when you pull this information. And going forward, one of the things that was laid out in the 2019 rule was that for cost reports that are submitted now, a detailed listing of the charity care needs to go in with the cost report. So before this time frame, that charity care listing didn't have to be submitted with the cost report. And obviously they're going to ask you for it during the audit, but now going forward for cost reports that begin after October 1st of 2018, the listings have to be filed with the cost report, or it is a reason for the cost report to be rejected now if that S-10 listing does not go with the cost report. So we will take a look at Medicare bad debts now and talk about some of the things that make a Medicare bad debt a Medicare bad debt, and kind of what I like to refer to this, kind of the 7 highly effective habits of a Medicare bad debt. So what all has to go into the different components of the bad debts that will allow it to survive an audit. So first of all, what is a Medicare bad debt? So this is Medicare beneficiaries' unpaid deductible and co-insurance amount related to covered services. So the regulations around the Medicare bad debt state that it must be related to covered services. There must be reasonable collection efforts were made, and there's a lot of scrutiny around what those reasonable collection efforts are that we'll discuss. The debt must be uncollectible when it's claimed as worthless, and we're going to talk about what makes it uncollectible. Right now, it's reimbursed at 65%. So your Medicare bad debts that you've identified and that you're reporting on the Medicare cost report, you will get 65% of that amount. That 65% has been a percentage that has went up and down over the years. At one point in time, when I started in this business several years ago, Medicare bad debts were being paid at 100%, and then ratcheted down over the years to 75%, down as low as 55%, and it's been at 70% for several years. So basically, over the last several years, hospitals have got 70% of their Medicare bad debts. Unless you were a critical access hospital, you were still getting 100% of your Medicare bad debts up until 2015. So in 2013, that 70% was changed to 65% for PPS hospitals. They now would receive 65% of the amount that they've claimed on the cost report. And critical access hospitals were phased down to that 65%. So they didn't get hit as hard quite as quickly, going from 100% down to 65% in 1 year. They were phased down to that over a 3-year period, but they too now are at that 65% of Medicare payments, Medicare bad debts. So the big thing around Medicare bad debts, the thing that make Medicare bad debt audits so challenging, is being able to maintain the documentation that says that this is a Medicare bad debt, that says that everything that needs to be done for it to be claimed as a Medicare bad debt was done. So how are you maintaining that documentation and making sure that when this debt is included in the Medicare bad debts, from that time on to the time that it's audited, where and how is the information maintained? So that's where a lot of issues come into play with these Medicare audits, and some large reductions in the Medicare bad debts is not being able to produce the evidence, the documentation that proves that bad debt meets the highly effective habits of a Medicare bad debt. So some of the things that are not included, that would be excluded from co-insurance and deductible amounts and wouldn't be reported on your cost report as a Medicare bad debt. So fee reimbursed services would not be excluded, would be excluded. Amounts related to professional services would be excluded. Amounts still at collection agencies would not yet be able to be included as a Medicare bad debt. Accounts that payments have been made on starting the 120 days over must be excluded from Medicare bad debts. So basically, if someone walks into your patient financial services, your billing office, and pays, $5 on a $1,000 bad debt, that would start over that 120-day period. And then Medicare HMO bad debts is not included in your Medicare bad debts on the cost report. We're going to talk about the Medicare HMOs a little later, because there are ways that maybe you can get reimbursed for Medicare HMO bad debt, not through Medicare itself, but through your HMO, who you've got it contracted with, there might be an opportunity there for you to get some reimbursement on those Medicare bad debts. So the first bucket of a Medicare bad debt is your traditional bad debts. So this is where basically a lot of work is put in here in this area in order to be able to claim this as a Medicare bad debt. So a traditional bad debt, it's your Medicare beneficiary, not a you will work an account for a certain amount of time, whether that be 90 agency. Even if it's over 120 days old, even if you've worked it, you've sent 3 statements, maybe you've made phone calls, whatever your policy says you're going to do before you turn it over to the collection agency, because it's at a collection agency and has not yet been deemed uncollectible, so it's not worthless, it cannot be claimed as a Medicare bad debt on the cost report. Reasonable collection efforts do have to be applied, and just kind of talked about those, and they have to be similar for non-Medicare bad debt. So you can't treat a non-Medicare bad debt any more aggressively than you do a Medicare bad debt. They have to be treated the same way. That same thing refers to the collection agency too. So if you turn over your bad debts to the collection agency, when you bring them back to be able to claim them, you have to bring back all of them. So not just Medicare bad debts. Your policy has to, be that you're bringing them all back after, maybe it's 240 days. That is at a collection agency, and nothing's been collected on it. Then it gets returned back to the hospital. So it has to be that all payers are returned back, not just Medicare. So if you keep them all at the collection agency to be worked, then Medicare has to stay there and be worked. So basically, the same efforts have to be done for Medicare as the same thing you're doing for non-Medicare patients. And one of the issues that we've seen here through audits that is being looked at and scrutinized very heavily by the MACs is timely fashion of a timely billing. What are your policies around this? This creates a little bit of a challenge because that differs between MACs. That timely billing date or days is different between MACs. And some of the things that we've seen, I've kind of got laid out here, that some MACs say that it's got to be you bill the MAC or bill before 30 days after discharge. Bill the beneficiary within 180 days of the discharge. So if you haven't billed your beneficiary their coinsurance and deductible before 180 days after discharge, that in the eyes of some of the audits that have been occurring, that's not timely billing. You're not timely billing this coinsurance and deductible. So that bad debt would be an error. It would not be an allowable bad debt. So that's something that you need to make sure you're paying attention to. What's your MAC, and maybe you've gone through some audits already and know this, but what is your MAC's policy around what that timely billing is, so that you're making sure that your patient financial office knows that and are billing these before that timeline expires, so that when these are audited, that's not something that can be brought up and in error would occur. Because as we all know, you know, when you find an error in the Medicare bad debts, it's not just losing that $1,000. You could be losing, you know, 15, 16,000 or more for every error. So it's extrapolated to the population, and that error factor is determined. So if you lose a $1,000 bill, $1,000 bad debt, that's hitting you for, you know, whatever that sample area is, which is much larger than amount. So it's really important that you're looking at all of these different areas to make sure that the highly effective habits of a bad debt are being met, because it's very expensive as far as what you lose if an error is found. Medicare Medicaid crossovers is another bucket. And a Medicare Medicaid crossover is a Medicare beneficiary that has Medicare primary and Medicaid secondary. And the big issue here is billing Medicaid. So you must bill Medicaid, and you must have an RA that shows that you, sorry about that, I jumped ahead of myself there, that you billed Medicaid and that what was paid by Medicaid. You know, in most cases, it's probably going to be zero, and that's what will show on the RA. But in some cases, there might be some payments that need to be subtracted from what you're claiming as a Medicare bad debt. So you will need to be able to show that you billed this, and that will be really the extent of your what needs to be done in order to claim this on your Medicare cost report. No additional collection efforts are necessary. So in a lot of cases, Medicaid crossover bad debts are the only bad debts that are claimed on the Medicare cost report. And I think just from the last slide we looked at, you can see why. A lot less work goes into the Medicare Medicaid dual eligible. All you have to do is bill Medicaid and have the RA. Whereas on the traditional bad debts, you saw there's a lot of different things collection-wise you have to do. So in some cases, it's just the Medicare Medicaid crossovers on the cost report. For two reasons, as I just mentioned, a lot of work to get the traditional Medicare claimed, and some hospitals have made the decision to leave their bad debts at the collection agency, all of their bad debts. So they may have made a determination that they get paid more by leaving it all at the collection agency and working it, than pulling back the Medicare and getting paid the 65% of the Medicare bad debt. So a couple of reasons why that may be the reason you see that sometimes. So another bucket of our charity care is, of our Medicare bad debt is charity care. So Medicare indigent charity bad debt is a traditional Medicare beneficiary that's deemed indigent. You went through all of your guidelines and policies to make that determination that they do meet your charity guidelines. They are not eligible for Medicaid. And as long as you can prove that they've met your policy, you can claim them as a charity care bad debt. No additional collection efforts, again, are necessary here. Again, indigence must be determined by the hospital. So you must take into account the patient's total resources. There's nobody else is legally responsible for this. And that indigence, again, must be determined. It must be documented in the patient's file. You must be able to show that you've taken the necessary steps to determine that they are charity. If you receive recoveries of bad debts, they do need to be netted against your bad debt expense, even if that bad debt was claimed in prior years. So if a patient that was claimed as a Medicare bad debt in 2016 comes in 2017 and pays a portion of that bad debt, then you need to subtract that recovery, that amount, from the 2017 Medicare bad debts that you would have been reporting. And as I mentioned, that payment would restart the 120-day period. So if it's a patient that has a Medicare bad debt and you have not yet claimed that on the cost report as a Medicare bad debt, and they come in and they pay that, $1, $5, $50, that needs to start over that 120-day waiting period. So it starts it all over just like it was from day one. So you have to wait that 120 days before you can claim it as a Medicare bad debt. So some thoughts around Medicare bad debt that's extremely important is sometimes bad debts are very old by the time that you claim them because of the return from collection criteria. So they could be at the collection agency for a year, 2 years, whatever your policy states. So once that gets returned and you are claiming that, you need to make sure you can locate the underlying documentation to be able to claim that. A lot of hospitals recently have went through some large cleanup projects. They may have, saw the writing on the wall a few years back about the possibility of the percentage getting lowered from 70 to 65%, and decided to do a large cleanup project to make sure they get everything pulled back. One of the issues around that percentage, that 65, that percentage that we're at right now, is every year we hear the talk from Congress about lowering that percentage, and at some point eliminating Medicare bad debts. So it could go from the 65% it is at right now down to 25% is a number that we hear quite a bit. Could go to zero. It could disappear as a payment mechanism. So being able to document all the documentation for that is going to be extremely important. Outpatient should have a different tab for traditional, a different tab for crossover, the Medicaid eligibles, a different tab for your charity care bad debts, because what you want to have happen is that each one of those different buckets are audited separately. So the sample that the MAC polls would be out of each one of those different buckets. So if an error that was found in the traditional bucket of bad debts, you want to make sure that's only extrapolated, that error is only extrapolated to that population, that traditional Medicare population, instead of the whole population, because of the different things that go on in those different areas. In some cases, contract auditors are used by MACs in order to audit the Medicare bad debts. This sometimes can lengthen the audit process, can result in more questions, more scrutiny, because these contract auditors may not be quite as experienced. So they're asking a lot more questions and maybe looking more at depth at a lot of different things. So that that makes that a more difficult process and probably a longer process. So this is the documentation that I talked about earlier, that really needs to be submitted with a Medicare bad debt log. So required, a bad debt log has certain requirements. That's what is listed here in the orange fields. So those are all information that always had to have been documented and filed in your log. The other side of this is suggested additional fields that we've seen as we've seen clients go through audits. These are some of those things that made it a little bit easier if these were in the logs to be able to identify information that the auditors were questioning. This led you to more easily recover that documentation and make sure that the things were done that needs to be done. Meaning, if there were recoveries, did that get taken away? Was a hospital chair care determination made? That should be, the data that should be marked on the log, and that way it's easier to determine where that information is at. The date of the first bill to the beneficiary, and the 120 day. So did you wait that 120 days to claim that? Date returned from a collection agency, that actually is obviously very important now. The MA, the Medicaid remittance advice. So having all those additional information there will help you be able to prove that bad debt is a bad debt. I mentioned Medicare managed care bad debt. Again, that's not something that is reimbursed through the Medicare cost report or the Medicare program, but there may be an opportunity for you to work with your who you've got your contract, or your Medicare managed care contract is through, to get paid for a bad debt. And of course, this depends on the size of your Medicare managed care population. If it's worthwhile to go through this and to try to claim that bad debt. But most of the time, Medicare Advantage plans that have this within their contract will pay similar to Medicare. Will still require the same kind of collection efforts. But it is an opportunity for you to maybe collect some revenue that had been overlooked, depending on how big your population here is, and if this is part of your Medicare Advantage contract. So if you think you've got a big enough population in this area, that might be something you want to take a look at. Some of the key drivers around Medicare reimbursement, we've hit most of these as we went through, and really the key driver is the most important and only one I've listed here, the key driver is auditable documentation supporting that bad debt. That's the key driver here. So what processes are in place to make sure that the max documentation requirements are met, and where is this information housed, and how can you obtain that information, whether that be in the patient file or electronic, or wherever that information is. Where is that information? Is this bad debt returned from collection policy? So have we got a policy in place to get this returned from the collection policy? The timely billing, understand what your contract or your MAC determines is the timely billing phase of that, and are you doing the timely billing properly? So these are some of those opportunity questions you can take a look at to gain an understanding if you're reporting your Medicare bad debts properly. So just a few more thoughts before I kind of open it up for a few questions over the last few remaining minutes that we've got. Things for you to kind of think about as you walk away from here is what's your organization doing throughout the year to understand these key drivers and make sure they're properly being implemented or properly being looked at throughout the year. Is there some kind of pre-year audit that's being done to make sure that this information is being captured properly? Now, how is your Medicare cost report used in strategic discussions? Meaning, the cost report has a lot of information in it, and by looking at that cost report and even comparing that cost report to other facilities, because you can get other facilities' cost reports, through different vendors that are out there that have the HCRS information put into a cost report. You can pull those cost reports and do some benchmarking things around another hospital's uncompensated care or Medicare bad debts that are similar to your size or in your same population, your same state, and get an understanding of, if one is much higher than your hospital and what needs to be done for that. So what basically the thought-provoking question is here is, how am I reporting things and making sure they're reporting properly, and is there a big difference between how we're doing things compared to other competitors, other hospitals in my area are doing? So hopefully, conclusion here, hopefully we've met those learning objectives we talked about beforehand, and I hope you take away some better understanding of some of these key drivers of these areas of the Medicare reimbursement that we talked about. But with that, I'll throw it back over for questions from the group over the next 8-9 minutes that we have left here.
Thank you, Chad, for a great presentation. Before I take our first question, I would like to remind everyone to type their questions into the questions chat panel located to the right of your screen, and we will take as many as we'll allow. I see a few here, so I will start with the first one. It says, what would be the max audit process for the uncompensated care audits?
Over the next several months, as they go through the first audits around this, and they refine their process, and they take a look at the information that they were able to get and the different things that they looked at, and maybe understand what they really.
Medicare bad debt. When do you claim that Medicare bad debt on the cost report?
Good question. Good question. Clarification there. A lot of before 2008, hospitals could claim that Medicare bad debt as soon as they turned it over to their collection agency. They were able to claim that as a bad debt. They did all the collections. It was 120 days. They met everything they needed to meet. But since 2008, that return from collection agency criteria went into effect. Basically, they were saying that it's not yet worthless. It's still being worked, so it's not worthless. And one of the criteria for claiming a Medicare bad debt is, it's got to be worthless. And it was determined that if you have it at a collection agency, it's still being worked. There's still the opportunity for recovery of that deductible and coinsurance, so we can't claim that as a Medicare bad debt. So since 2008 and going forward, you cannot claim that on your cost report until it is returned from your collection agency.
Got it. Great. And then the third question here is, what lines on S-10 comprise the uncompensated care costs?
So on S-10, as we talked through that, I mentioned there's a lot of different areas that's being reported on S-10. And all of the information reported on S-10 is being looked at as your total uncompensated care that would be looked at by outside your hospital, competitors, your tax 990 information, the scrutiny that not-for-profits are under, would take into consideration all of that information that's on S-10. But for purposes of that redistributed of that pool that we talked about, so for hospitals to get their portion of that payment, that is line 23, which is the charity care cost, and then line 29, which is the non-Medicare bad debts. So those two lines would be added up, and that would be what is used to determine your portion of the uncompensated care payment that your hospital will be paid.
Awesome. Okay. Well, as we approach the top of the hour, I would like to take this time to thank our members and healthcare community for joining this call. Be sure to join us next month for another installment in our webinar series. Thank you again to our guest speaker, Chad Kershall of Crowe LLC. Have a great afternoon, everyone.
Thank you, everyone.